Hello students and doctors. Now our next topic in small intestine is lactose intolerance. You have most of you know how about this topic, so we are going to cover it in a very fast lecture. So the video is going to be short. If there is anything important, I am going to tell you. So what is definition? Define inability to absorb lactose. Very simple. If a patient is unable to absorb lactose, what is a lactose? Lactose is a disaccharide made of glucose and galactose, usually present in milk and milk-based products. Why a patient is unable to absorb lactose? Due to lactase enzyme deficiency. Very easy. So if a patient who is having lactase enzyme deficiency, the patient comes to you with lactose in his stools. So how patient presents, we are going to discuss in our next clinical feature point. So what is the epidemiology? About 70% of world's population. Epidemiology, very important in clinical section. A patient comes to you and ask about the history. A patient comes to you with a clinical presentation of diarrhea. You ask about what is the history and nature of diarrhea, consistency, color, volume, and you ask about other features of diarrhea, whether it is taken with food or after food ingestion, what kind of food you took in evening or morning, what else, what fluids you take, and you ask about the food intake history in diarrhea, most important. So you will rule out whether it's a food related diarrhea or it is due to some acquired cause. So about 70% of world's population is lactose intolerant. So you are thinking about, it's a huge number. Why people do not present with so much diarrhea? Because people consume usually 1 glass of milk, which contains about 200 to 300 ml of milk. So if a patient consumes 200 to 300 ml of milk, his body is able to tolerate this 200 to 300 amount of lactose in his body. So patients usually do not present in early ages. Its prevalence increases with age. So what is the etiology of lactose intolerance? Etiology, we are going to discuss very briefly about the etiology. So there is two causes, whether there is no production of lactase enzymes primary, and it is the most common, and secondary. In secondary causes there is acquired cause. What kind of acquired cause we are going to discuss in later. So in primary, lactase enzyme is deficient. Lactase enzyme is deficient. Due to deficiency of this enzyme, there is inability to absorb lactose, so patient presented with diarrhea. So in secondary, due to any underlying disorder of small intestine which is causing mucosal damage. So any disease of small intestine which causes mucosal damage, patient comes to you with diarrhea and can presented with diarrhea and may have lactose intolerance. So what diseases causes? Let's touch some diseases like autoimmune disorders. We are going to explain in our next section. What autoimmune disorders can cause lactose intolerance? Gluten sensitivity enteropathy. You getting it? Second thing which causes gastroenteritis, which gastroenteritis can also cause mucosal damage, usually rotavirus causes gastroenteritis, causes viral gastroenteritis can also lead to mucosal damage, and this secondary cause can also cause lactose intolerance. So usually those patients, those children which are born premature, uh, or usually premature babies have this lactose intolerance, because lactase is a brush border enzyme of small intestine. You know the feeder washer, like this this is a feeder washer brush. So like same the way in intestine there is brush border enzymes which are produced in borders which look like brushes. So lactase is a brush border enzyme, and these lactase develop during late pregnancy. In late pregnancy, lactase produces. So if a patient, you will ask about a patient comes to you of 1 or 2 3 months history, or 2 months history, or 4 or 5 week history of like a 4 weeks old baby, or a 3 months old baby comes to you with diarrhea, and you ask about whether the diarrhea is associated with the milk intake or not. The mother will tells you that it uh, uh, cries with diarrhea as well. The diarrhea is bulky and frothy in nature. So you will ask about the pregnancy history, whether she gave birth to a premature or a complete pregnant baby. So it's a very important to ask about the clinical history. uh, so the next cause is congenital disease. In those diseases where autosomal recessive gene defect is present, autosomal recessive gene defect is present, it's a very rare cause. So you, if you don't remember it, it's okay. So what is the pathophysiology? What is the pathophysiology? So how this clinical feature of diarrhea develops in a lactose intolerance patient. So what will happen? As I already told, lactase is produced in brush border of small intestine. So what will happen? This lactase cleaves lactose. Lactose is a combination, is a disaccharide combination of 6 molecules of uh, 6 carbon compound. One is glucose and the second one is lactose. Lactase cleaves these glucose and lactose bonds and form into glucose and galactose. These monosaccharides are absorbable. You are getting it? These are absorbable by the action of lactase. Disaccharide is converted into monosaccharide. These monosaccharide are glucose and galactose, which are absorbable. Lactose is not an absorbable disaccharide. So what will happen in lactase deficiency? There is absence of digestion. You understood the pathophysiology already, so I am going to explain it in a very easiest way. Absence of digestion of lactose results in decreased absorption. So the next important feature we are going to discuss about the lactose is, this is a osmotically active agent. Osmotically, in a very simple way, ये एक ऐसा molecule for Pakistani and Indian students, it is that kind of molecule which attracts water towards itself. Like ये पानी को अपनी तरफ खींचता है. एक ट्यूब के अंदर अगर पानी पड़ा हुआ है तो वहां पे पता है कि यहाँ पे ना एक चीज पड़ी हुई है. अब इसने लाइक ए मैग्नेट, इट एक्ट्स magnet to attract hydrophilic compounds towards itself. So you are getting it. Lactose is an osmotically active agent. So what will happen when there is decreased absorption in small intestine? This lactose is acts as an osmotically active agent and it attracts water towards itself. This leads to, so the thing is that this lactose is also passing from small intestine and moving to large intestine. As it travels from small intestine to large intestine, it keeps attracting osmotically active molecules toward itself. So it attracts water molecules in simple way towards itself. So what will happen as it leads is, as it enters large intestine, as it reaches large intestine, it form a bulky amount. It's, you get why it's how osmotically active and how a bulk is formed in lactose intolerance. So patient comes to you with diarrhea. So what will happen, the next thing in pathophysiology is it increase peristalsis. So when the peristalsis is increased, the as peristalsis increased due to increased intestinal filling, you getting it, this single amount attracts molecules toward itself. When there is intestinal filling, there is increased peristalsis, there increased peristalsis due, it leads to abdominal pain. When there is abdominal pain, patient comes to you with I am periumbilical and lower abdominal pain along with diarrhea. You will ask about his food intake history. In diarrhea, very important, you ask about the food intake history, and you ask about the nature, volume, consistency of diarrhea and amount of diarrhea, amount of stool passed, and other mucus history. You can check my diarrhea complete videos in 4 parts. I uploaded it already. So increased peristalsis leads to increased intestinal filling. Increased intestinal filling leads to abdominal pain. How abdominal pain develops, I already told you the pathophysiology. So the next thing is there is intestinal bacterial flora. Bacterial flora, human friendly intestinal friendly bacteria are present in intestine. So what will happen, these bacteria metabolize lactose. As lactase is not present, so lactose is passing from stomach to small intestine and to large intestine. So the metabolism of lactose in colon leads to short chain fatty acids. These short chain fatty acids exacerbate diarrhea. So the diarrhea will be of fatty in nature, and there will be increased gas production and flatulence. So that's the pathophysiology and clinical features. We are discussing the, we are going to discuss about clinical features. How patient presents to you, patient comes with diarrhea. The main chief complaint is diarrhea. Next thing is cramping, abdominal pain. So the third thing is bloating, abdominal bloating and flatulence. The next thing is nausea. These are the 4 clinical features which are present in almost all patients of lactose intolerance. So what will you do? You will ask about diarrhea, whether it's watery or fatty. So in lactose intolerance, there is small fatty acids, small chain fatty acids, but the diarrhea is of watery in nature. As lactose is an osmotically active agent, it attracts osmotic hydrophilic compounds toward itself. So watery in, and what will happen, bulky in nature, very huge amount of diarrhea patient presents with, and how these 3 features, you will ask about whether it's watery or fatty, whether your stools are in small amount or large amount. Patient says very bulky amount. So what will you ask, you ask about whether it produces froth or not. Patient tells you it produces froth. In Pakistan or in India, you have seen a milkman milking a cow. So whenever he milks a cow, there is froth on upper surface of the milk. This froth reminds you of lactose intolerance. So how you got it, how crampy abdominal pain is developed. So this abdominal pain is usually periumbilical or lower abdominal. So why crampy abdominal pain? Due to increased peristalsis. Why increased peristalsis? There is increased intestinal, I already told you, there is increased intestinal filling which leads to abdominal pain. So why bloating develops, why flatulence develops? Due to metabolism of lactose by colon flora. So patient will have sensation of nausea. So how will we diagnose it? As very simple and very easy. You are going to diagnose, you ask the patient not to take milk or milk made products for 1 week and come to see me. In poor countries you can use this as your diagnostic tool, like trial lactose free diet. So if a patient comes to you after 1 week and tells you that he is having no more diarrhea, so you confirmed your diagnosis that he is having diarrhea due to milk or lactose. So we will diagnose him lactose intolerance, and you tells him that you are going to be on lifelong lactose free diet, or you are going to have lactase enzyme from outside. The next test we are going to perform is hydrogen breath test. Hydrogen breath test. The amount of hydrogen in the expired air increases after after we administer lactose to patient. We ask the patient to come to us in a fasting state or early morning, or we ask the patient to have an 8 hour fasting and come to us after 8 hours. We'll give him milk or lactose, and after giving him lactose we'll ask about his breath test, and we'll see 8 to 12 hours of fasting ingestion of lactose, and we'll measure breath hydrogen level at 30-minute interval over 3 hours. So next thing, if there is hydrogen levels more than 20 ppm, this is the diagnostic point of hydrogen breath test of lactose intolerance test. Next thing is lactose tolerance test. What we are discussing intolerance. We'll see about lactose tolerance test. We give our patient lactose. There is normal rise in blood glucose. The normal rise in blood glucose level is pathologically reduced. So this test has low sensitivity and specificity. So next thing we are going to, after lactose tolerance test, we administer him or give him lactose, and we'll see glucose level. As lactose is not cleaved or divided into glucose and lactose, there will be no rise of glucose in the blood. So we'll see there is no glucose rise, which tells us that lactose is not tolerated. So next test is our stool analysis. If you have any question you can ask me. Stool analysis. There will be increased stool osmotic gap, and there will be decreased stool pH less than 6. Like patient comes to you with acidic stools. Why? Due to lactose fermentation. Lactose is fermented by colonic bacterial flora. So in early minutes of our lecture we discussed about the primary and secondary causes of lactose intolerance. If there is any secondary cause like gluten sensitivity, enteropathies, so there will be mucosal damage. To check out the whether mucosa is okay or not, we'll go for biopsy of small intestine. So it's a qualitative and quantitative assessment of lactase via endoscopic tissue biopsy. So what will it tell? It differentiates between primary and secondary cause. If the mucosa is all okay, there is no mucosal atrophy or mucosal degeneration or mucosal injury or damage, we'll rule out that it is not due to any secondary cause. We'll label it as primary cause. So if mucosas are damaged, like intestinal villi which are present in our intestine, the tips are damaged, we label it as secondary lactose intolerance. So we'll ask about histopathological findings relating to the etiology we discussed in early minutes of our lecture. So what are the differential diagnoses? Very important point of our lecture is differential diagnosis. You have to be in your mind. So food allergy, also patient comes to you with a crampy abdominal pain and diarrhea. So especially IgE mediated food allergy, like I am intolerant to egg yolk and chicken, and after consumption of egg yolk and chicken after 4 or 5 hours I develop diarrhea and crampy abdominal pain. So food allergy can be IgE mediated and non-IgE mediated. We'll discuss it some other day. So next thing is food allergy. Next our differential is food intolerance. Food intolerance. The third differential diagnosis is IBS, irritable bowel syndrome. Patient, we are our next topic is going to be about IBS. So the third thing is IBD, inflammatory bowel disease. Whether there is any inflammation like Crohn's disease or ulcerative colitis in our colons or small intestine or GI tract, we are going to rule out about IBDs. So next thing is any GI infection. These are our differentials. So cystic fibrosis. What will happen in cystic fibrosis? I told you, you are very much clear about cystic fibrosis. Bowel malignancy, we are going to place bowel malignancy in our very end of step ladder. So how will we treat the patient? treatment Treatment is going to be very important point. First of all, we are going to advise and counsel the student to avoid or reduce intake of milk products. Treatment, you're gonna ask the patient not to consume so much milk or consume in a very limited amount. The next thing is you will tell the patient to reduce intake of milk based products or those products which are lactose free or lactose reduced products already available in market. So what kind of alternative drugs we can give? We can give soy based products easily available in developed countries and very difficult to access in peripheries of Pakistan and India. Next thing is we are going to give him supplements. What kind of supplement? As patient is not having lactase enzyme, we are going to supplement him lactase orally. Whenever patient is consuming lactose or lactose based products, we are advised him to supplement himself with lactase orally. So these lactase enzymes supplements are present over the counter. You can take from any pharmacy. So if there is any secondary cause, what will the treatment? Treat the underlying pathology. That's all about lactose intolerance. So our next topic is going to be IBS. Stay tuned.